Hello, my name is Carol Carter, and I'm the founder and CEO of Global Minded. We are about creating a capable, diverse talent pipeline by getting more women, people of color, LGBTQ, all manner of diversity, how you can define diversity into the education, employment, and economic mobility pipeline, including into the C-suite and onto boards. So we have a number of equity teams across the different disciplines, and they meet monthly to tackle in courageous conversations some of the specific things that need to be solved right now. So this is our health equity team, and on behalf of Dr. Monique Butler, who actually had a family emergency today, or she would be joining us, as well as Dr. Pierre Theodore, who has been involved in these sessions. So we're glad that you're here. We will be recording this session. We will follow up in a couple of days with the link to the YouTube channel, so you can share this out with your networks. And just very pleased that these incredible people are going to be here for the next hour with all of you, and would like to hand it over to Dr. Theodore. Pierre?
Great. Carol, thank you so very much for the introduction. Really very much appreciate that. And for all that have joined today, I'm very grateful. And I think we have an interesting discussion, and I hopefully it'll be sort of wide ranging around issues related to Indigenous health, and perhaps even referring a bit to military veterans as well. Fundamentally, I think tending to focus on issues of health equity and what are some of the underpinning causes for the inequalities that we see in terms of healthcare outcomes. We've got a remarkable panel today of Celeste, Jandel, and Jessica, Mary, and Shri, who will speak to their individual programs and walk us through some of their approaches to health equity. I wanted to start off, if I could, however, making a couple of very brief comments, if I may. I'm going to try to share an image. And I suppose if we're going to speak to issues related to Native peoples and Indigenous peoples in the land of the United States, I should start by recognizing that here, sitting in San Francisco, that I actually am sitting on the ancestral lands of the Miwok people, the Ohlone people, the Ramnashtay people as well. And I should acknowledge the Indigenous people where I sit to this day at this particular time. I wanted to actually start off, if I could, with a little bit of a personal story from medical school. And it really drives some of the way that I'm thinking about health equity right now. And let's look at the far right side of the screen. And what you will notice is that when you look at the Native peoples of the Pima Indian tribe, you find up to a 50% risk of type 2 diabetes. And I remember this very clearly from medical school, being trained on the incredibly high rate of type 2 diabetes among the Pima Indian people. And as a result, we were then told, if you move a little to the left, that this was a biologic process, something involving insulin sensitivity and a high rate of type 2. And maybe there's something we could learn about diabetes by studying this one population. And it stopped there. So when I graduated from medical school, I left thinking that there was something biologically distinct about the Pima Indian people that led to this high diabetes rate. But never did anyone move a little further to the left here and ask about the health practices, psychosocial stressors, start to talk about things like the Dawes Act in 1887 that really undermined the Native peoples and disabled some of the social interactions. Many of the facts that some of the people in the Pima lands were not allowed to leave the reservation in order to gain food and nutrition sources from elsewhere. So all the food that was coming in was low in nutrients and high in sugar, for example, starting to drive this rise in obesity and type 2 diabetes. So if you will, it sort of stopped at the observation and maybe a belief that this was a biologic process, but never were the sort of, quote, social determinants of health addressed. And that is, in my mind, a real missing issue in health equity. And most of those who are on the call today will speak to some elements across health, these sort of underpinning causes that lead to these differences in health outcome. And as you can see, when we look at the social determinants of health across economic stability, neighborhood and physical environment, education, food, social context, and the healthcare system itself, I think about what I would call sort of deserts that exist around us all the time. And they're either, in some cases, literal, so there's a geographic distance to healthcare, but sometimes it's conceptual. I grew up in Baltimore, and there were often divides that did not allow for accessing healthcare to lower income residents of Baltimore, Maryland, for example. So it's not always a geographic issue to have a so-called healthcare desert. And certainly things like nutritional deserts are well described that then translate into the health equity issues that we have seen. So the Native peoples now, as most on the call may know, who are then, who carry the label of Native peoples in the United States, measure about 6 million people, 20% of which are currently on reservations. The interplay is with the Center for Medicaid and Medicaid Services through the Indian Health Service that has a distinct budget each year. And that budget is woefully insufficient given the healthcare demands on most reservations at present. I would also point out the fact that in a sense, the Native people have been sometimes termed an invisible minority. So at the same time that they have many of the same health equity issues that other marginalized people do in the United States, the relative emphasis, perhaps because of their, at least on the reservations, a sovereign status, has led to this sort of status where they often are overlooked. And I think that starts to drive some of these additional healthcare inequalities that we have seen. So with that as a backdrop, Shri, I thought maybe I would turn to you, if I might, to sort of pick up the ball and run with a little bit. Tell us a bit about the programs that you were leading and help to kick off our discussion today.
Sure. Thank you so much. And thanks for having me. So my name's Shri. I am a medical doctor at UCSF, and I've been running this global health program called the HEAL Initiative, which stands for Health Equity Action Leadership. And we've been working in Navajo Nation for the last 6 to 7 years. And so I think a lot of the disparities that Dr. Theodore talks about is, have been chronically present in Navajo Nation. And when we're working in Navajo Nation, it's been a place where the level of disparities existed long before COVID. And like many people say, COVID hasn't caused that many new problems. It's just poured gasoline on a lot of the old problems that we've seen. And so I think we started working in Navajo Nation in 2015. And in Navajo Nation, there's a 30% health workforce vacancy. So they have, even though they're under the US government with the Indian Health Service, they have 30% of their physician jobs and nursing jobs that are completely vacant. And so though they have money, they can't fill those jobs. And so when I started working as a resident, I was interested I was working in South Los Angeles, and in the county hospital. And like Pierre said, we start seeing kind of the social determinants of health, the structural determinants of health of the population that we're taking care of. Really, as a clinician, you start seeing the same patients come back into your hospital, and you start wondering, am I really addressing the root causes of disease? So I came out of residency wanting to serve an underserved population. And I did a lot of work internationally in Haiti and Rwanda and Burundi. And we also wanted to work domestically in the United States. And so a lot of times folks would say, as you think about working internationally, there's so many communities. I remember a residency director in New York said, there was, as residents or people that are interested in health equity, fly across to, go from Manhattan to JFK Airport and go to Haiti or elsewhere. There's a lot of communities they pass domestically that are deeply underserved. And so we wanted to focus on domestic communities and international communities. And so the program we built, HEAL, is a health workforce capacity building program that works in underserved areas in 9 countries around the world, including Navajo Nation. And so Navajo Nation, because I think we're focusing on Navajo Nation today, we had 52 frontline health professionals that were working, that were either part of HEAL or alumni of HEAL that were in Navajo Nation before COVID started. And half of them were kind of US doctors that were outsiders to the community, and half of them were Navajo health professionals. And so we had a large footprint on before COVID. And so when COVID hit, and now it's starting to surge again in March and April of this year, a lot of our colleagues that were Native colleagues started to say, we have a massive workforce shortage of nurses, of doctors, and can you come support? And so I think just going through, some of the data that Pierre talked about in Native communities, we know that Native across the country, Native individuals are 5.3 times as likely to have been infected by COVID. I think in New Mexico, the rates of 36% of cases in New Mexico, which is where Navajo Nation sits, New Mexico and Arizona, are Native Americans, but only 9% of the population. And so it was, I think for me, it was very interesting in going to Navajo Nation. I spent 6 weeks there in the spring taking care of COVID patients, and a lot of the media would interview me, and the initial question was, why is there such a surge in Navajo Nation? And so what we have to look at is this moment tied to historical, if you look at the 1918 flu epidemic, for example, in Alaska, 80% of the mortality was in the Native population. If you look at the H1N1 epidemic in 2009, they had a 4 to 5 rate of death amongst Native population than in the general population as a whole. So actually in places like Navajo Nation that's had a huge COVID surge, the question of why is there a massive outbreak here doesn't really arise for people that have that deeply know these communities, because these communities have been resilient for a long time, but they've also been disproportionately impacted for a very long time. And so COVID is just one more pandemic that has just disproportionately affected Native Americans. And if you going to Pierre's kind of beautiful framework in the beginning, the structural causes, I think sometimes we want to focus on, diabetes, obesity, alcoholism, all of those things which are at a higher rates in the Native population. But if you want to look at the why behind that, I think that's where we want to go. And so, for example, in diabetes, obesity, Navajo Nation is 27,000 square miles. It's the size of West Virginia, and it has 13 grocery stores on it. West Virginia has 162 grocery stores, right? So you're looking at a food desert there. And if you're looking at a population that a third of them lack access to running water and electricity. And so the infrastructure challenges there. And so I think of the reasons why there's a massive COVID surge in a lot of the Native populations are mostly structural, where there's been genocide, there's been broken treaties. As Pierre mentioned, IHS has funded 1/3 the rate as Medicare and the Veterans Administration. And so you have structural reasons why there's a deep COVID surge. And then you have things that are part of the community, that this beautiful expansive definition of family where multiple family members live together in multiple generations definitely is spreading COVID, and diabetes and obesity as well. And so maybe I'll stop there, but I think that we are seeing this great disparity in COVID mortality, hospitalizations in the Native population. And the program that I run is really focusing on the health workforce side. And so how do we have Native, I can tell you when I was practicing there in the spring, to have a Native nurse that knows the patient really well, speaks the language, it's just a level of confidence that the patient has. We're all in PPE, we're all kind of not having the patient interaction that we want to have, and having more Native-led health providers take care of their own population is the goal. And so that's why we exist as an organization, to kind of grow the pipeline and health workforce of communities of color, whether it's in the United States or internationally.
Fantastic, Sri. And in the panel discussion, I'd love for you to dig into a little bit more of how you really are going to expand that pipeline, and to your point that you just made, is how you really get sort of local, culturally competent care to be delivered. So I'd love to hear more about that. Mary, can we turn to you? I'd love to spend some time hearing about your programs and give you a bit of a chance to walk us through the work that you've been doing.
So I don't remember what's listed on the bio prior to this conversation, but I'll just point out that I'm the current president of the Association of American Indian Physicians, which primarily works on workforce and recognizes that there are only about 40 out of 20,000 physicians that are Native American graduating each year. So there might be a 30% vacancy rate down in the Southwest or Arizona area. There's a 50% vacancy rate for physicians in the Bemidji area. And you can bet that there are hardly any Native physicians filling those roles. My school has the second. I'm also assistant professor at the University of Minnesota Medical School and lead the Center for American Indian Minority Health. It's a at least 45-year-old program that is dedicated to increasing the number of Native physicians. And we start from grade school on up. Most currently when we're primarily grant dependent, although we do have a lot of money from some money from our school. But our programs have focused on taking Native students and beefing up their scientific and math aptitudes so that they're more capable of getting through college and then into medical school. But I'll remind people that we in Duluth, Minnesota, and it's not too far off in other areas, the high school graduation rate for Native students is about 60 to 70%. In Duluth, Minnesota, it's 50%, and it's not much better than that throughout the state of Minnesota. So if 50% of the students are graduating from high school, maybe 20 to 40% of those go into college. And then how many of those graduate and go into STEM fields and are therefore able to go into medical school? Their number is paltry. So we need so much help in developing a better workforce. And I completely agree with the previous speaker, Shri, that it is so important that our faces be represented in those clinics. One, it's important that we be there. Two, we're more likely to be there in the first place because these are our homes and they're where we came from. And some of them are difficult places to work, like in the middle of South Dakota or in Alaska, where I'm from the Tlingit Nation. So we really work on our primary work is on workforce development, or efforts are on workforce development. The other thing though that the center is and AIP is focused on is this visibility issue. You're right that we are called the invisible minority, and right now we're seeing it on CNN. There was a recent graph that talked about the disparities in COVID, and we were featured as other. Again, despite the fact that we know, at least in Minnesota, that age adjusted, we have the highest mortality rate by far, at least 40% greater than any other population. APM research, I believe it's called, has our statistics, but it's only representing 38 states. So it's missing data. Another issue that we face is we don't have enough data. And it's largely because of these trust issues that are inherent from the history that you spoke of, Pierre, and that you hinted at as well, Shri. So addressing visibility, also just educating people on basics like the trust responsibility of the US government to provide our healthcare and where that comes from, all the lands that were given, the DAWS. The DAWS Act is one example of the trauma that our community has faced and is still reeling from. The people don't understand that you cannot talk about alcoholism, you cannot talk about any of these diseases until you're talking about the trauma faced by boarding schools, by relocation, by termination, all of that. And I think that people are ready to hear this, and when they hear it, they're ready to start to change ideas, and we can build momentum around that, like legislation and executive acts, but enough people don't know the history and they don't know the true story. So many people think that we still get free healthcare. So half of our job is just letting people know. I mean, I can't believe how many people I've had to give talks to who don't know those basics. And it's not, nobody's wrong, nobody's bad for not knowing those, except for our government, has colluded and made history, allowed this history to be told without us. Not just us, but lots of different populations. So that's another focus that we need to, the curriculum is another area that we need to focus on. So visibility, curriculum, getting this story, changing this narrative, right? And then in getting us better funding from the Indian Health Service. We are, as you mentioned, only partially funded, maybe a third of what and luckily the president-elect has a platform that recognizes that and is increasing plans to, we need to pressure him to do this, put more funding into that budget, but also address other things like the importance of self autonomy which I think has not been listed here, but really impacts our health. Michael Marmot's work on autonomy and the importance of self-determination, I think, is critical for my community. When we have that, I mean, it took 500 years to decimate our health systems, and we had them. We've only been in charge since, and it's funny, ironically, Nixon really started pushing self-determination, and we started getting control ourselves. But that's where we need to go. We need our healthcare funded. We need people to know that we're here. They need to know why we're here. They need to know the disparities that are happening. And then we need to be left alone to run it ourselves. So thank you.
Could not agree more. And I'd love to, when you referred to really the sort of the historical underpinnings and having a deep sense of understanding of sort of the historical backing to some of these disparities, that sort of study of structural racism, that sort of study of the underpinning causes is absolutely critical if we're going to come up with critical solutions. So, and I agree with you about the president-elect, because frankly, we were heading into a period where it was going to effectively be impossible to really study the fundamental underlying critical race theory and structural issues that underlie some of these equity issues. So I think that point is really well taken. So on that note, maybe at this point, Jessica, we can turn to you to hear a little bit about CellEd, and at some level, what is being done at sort of through digital tools to improve the capabilities of adult learners. And I'd love to hear a bit more about your program now.
Great, thank you, Pierre. And thank you so much, Mary, and Sri as well, for your important comments. It's just an honor to be here. Thank you, Global Minded, as well, for bringing us together to speak to such important issues. I have a few slides to share, and I look forward actually to the panel conversations. I think there's so much incredible, not only historic, but present trauma that we need to acknowledge in every practice that we do, and bring more tools to the table that are customizable, flexible, agile, can be used by communities who should be determining their own futures and helping us to heal our current and past. So CellMed is an example. I am the founder and CEO of essentially a public benefit corporation, an agile team of teachers and health practitioners and technologists who decided to come together to get along, if you will, in order to address some of the most, we would say, systemic inequalities of our time by using mobile learning and access to tools that are truly universally accessible. CellMed is a division of CellEd. CellEd started in 2014 with a simple promise. If you could reach, engage, and provide a tool for folks to co-create for themselves, we can ultimately provide access to the fundamentals. This was the idea, and we started with non-literate and low-literate adults in their first language. Said that if you can reach them over a mobile device, even without internet, with audio and two-way texting, and we learned together from there. Today, we're able to reach millions of folks over mobile audio texting that is also fully customizable, also captures all engagement, and compare everyone with a live coach from local communities and otherwise. So what we found in this humble exercise of reaching and engaging some of the most vulnerable populations is that we have so much more work to do, and hopefully together. CellMed launched this year. It was after a year of testing, and over time, we've been engaging in healthcare since the beginning, because at the fundamental level, where most people don't have access to food, shelter, adequate healthcare, and education, they're intersecting. They're not conveniently parsed into, let's provide an education solution or a health solution or a finance solution. At that point of ultimate need and access, it's intersecting. So we've worked in healthcare since the beginning, and over time had more requests from both our providers, care teams, and patients that they would like more to be done 100% remote. And so CellMed launched, and essentially what we do here is provide that access to a health coach, access to information that's made at a readability, a relevance, and a language level of our learner in less than 3 minutes over a phone, even without internet. and over time can increase access to programming that was unavailable before. Why do we train, engage, and even certify today's health workers and patients via a 100% remote learning program that is universally accessible? 1 in 3 adults lack essential skills. Level 1 of reading, math, and digital literacy and language. In today's world, where most information resources are made available online at a level 4, college or higher, we're essentially not providing information and critical access to today's information age. So what happens when we leave out most of the people from accessing information they need to thrive? Most are not. If you're 1 paycheck away from poverty and more in the United States, and we don't talk about it, those hidden epidemics, as you can tell, have exacerbated under COVID-19, and they're no longer hidden. The digital divide impacts so many people. I'm born in the Silicon Valley, and the myth is that everyone has access to internet and a computer. And since I've been in this space 26th year, actually looking at how untrue that is, the fact is most people don't have access to resources that are relevant, accessible, or affordable. So what do we do about that if we continue to design for very few? Well below 1% of mobile solutions, digital solutions are designed for any of these needs. But we all need essential skills and access to thrive. So why don't we start again together by co-creating solutions. This is an example of a customized solution that we've developed in partnership also with the VA, the Society for Vascular Surgery, clinic care teams and others, and the patients themselves who experience peripheral artery disease, don't have access to in-person remote therapy. What if you could get that over your phone that you have, any phone that you have, get that therapy every week, help you with those encouraging behaviors in order to improve your outcomes. So we're in our 2nd phase of research and piloting, and we work to expand more. Key to it is it's designed for, again, to be responsive to the patient first, their language, their experience, their sets of needs. How do we continue to engage patients with such different needs, pair them with health certified coaches that can respond to those needs, and ultimately keep growing together to improve programming? Another example quickly is where we really see universal access is critically important. The state of California Department of Social Service doesn't have a way to reach families who've lost their homes to fires in many cases. They aren't able to reach all the huge number of folks who are unemployed to date. And even more so, under COVID-19, the CDC information was made available, as I mentioned, at a level 4 on the website. We converted it, made it available via call-in 3-minute increments. And across 58 counties, there's so many other needs for accessing to the simple benefit programs. You can't get your food stamps unless you're doing a certain number of hours. How are you doing that if there's no remote programming available? We're now making those types of programs available again via any mobile device, pairing folks up with live coaches to be sure that if there's digital, literacy, language, or other issues, we're starting first and are learner-centered. One of the newer programs that we're working with is with the tribal authorities and communities to figure out what needs are, have folks tell us the needs, and co-create and design in particular for them. So I'll pause there. I look forward to the panel discussion, and just to let you know that with customizable solutions that can listen and learn in our humble first, we really hope to be a player at the table.
Jessica, thank you very much for sharing that. I was particularly, being in Northern California, of course, and the wildfires that we've experienced lately, I very much appreciate this idea of being able to reach out to at an individual basis to clients. So thank you for sharing that. And Dr. Alan Davis, as a CEO of a medical center, maybe I can turn to you to talk a little bit about your program in rehabilitation and beyond in terms of how you think about health equity. And if you could just sort of bring us up to speed on your program and your approaches, that would be great.
Great. Well, thank you. And thanks for the opportunity to participate. I actually thought, though, I would way back in my career and relate a few stories to where we began this. Because I think inherent in that, and a number of the comments that Shri, you made, as well as Mary, are some answers and a policy or advocacy approach I have been talking about for at least 20 years we need to get back to. And that is that I graduated from medical school in 1984. and then took off to Philadelphia to do my residency in OBGYN at Jefferson. And then left Jefferson and went to Tuba City, Arizona, and spent 4 years on the Navajo in the Indian Health Service. It was 4 amazing years. I was a National Health Service Corps scholar, had that scholarship. And I got that scholarship and chose it over the armed forces. So I had a choice of Air Force, Army, and IHS when I applied for med school funding, because I wasn't going to go to med school unless somebody paid for it, given my family, and chose the National Health Service Corps. By my 4th year in medical school, that was Reagan's 4th year in office, he had cut the commission corps significantly. He'd cut the funding to the National Health Service Corps. When I think about over time what that has done in terms of pipeline, let alone access, I think it's one of America's crying shames. And at the same time, they cut the funding. That was about, so when I got to the Navajo reservation, I hope this isn't viewed as anything other than affectionately, as we called it, the Res in 1988. It was about then that they started cutting funding to the Indian Health Service. And it was also about then that they started allowing insurance to cover. And in fact, we needed insurance to cover the services for those who were employed and had employer-sponsored insurance. And my husband actually worked there and did a lot of the IT work in getting the systems up to allow billing. In fact, I remember jokingly saying, they like you better than they like me. And I delivered babies for 4 years, but you enabled them to bring money into this place through setting up billing systems. So I was I certainly get Navajo to the extent that one can after 4 years, and that's about that. And I say that humbly. I also do know that access to care, it's sad to hear the numbers you're saying, Shri, Mary, in terms of the % of roles, Shri, that go unfilled. And it's really, really, it's more than tragic. It's another one of America's stains that we have not increased the pipeline for Native American folks who can go to medical school. And so the advocacy sort of story and all that is we need to bring back the National Health Service Corps. We did not have physician or dental or nursing or even mid-level practitioner shortages back then because we had obligations, and there were people who ducked them. We know that, but most of us did our time. I mean, the vast majority of people did their time, and there was a ready reserve of physicians and other care providers for both rural areas around America, for sure our reservations, and even in our urban health manpower shortage areas. I had a chance later to chair the American College of OBGYN's American Indian Alaska Native Committee on their affairs. And we did site visits, maternal and child health site visits all over the country where there were on the reservations, and had a chance to spend some time in Alaska. And back to the Self-Determination Act, that is called 638. By the time we got there, I think the Alaska Native Indian Health, well, it wasn't even Indian Health Service, it was tribal. And it ran beautifully. I've lost track of a lot of what's gone on, but it was, I was actually able to tell you envious of what and how Alaska had set up its networks. And there were things that we all could learn in terms of how you deliver care remotely, and that it doesn't take always, I will say, the person with the most letters after their name to deliver amazingly socially and culturally proficient and appropriate care. And in fact, the most trusted people, exactly to the point you made, Mary, are folk who look like you. And I dare say who look like me, because I was much more trusted by my Native American, and it was Navajo and Hopi patients, because they tell me that. I'll never forget this one Navajo patient telling me, I trust you because you're a colored woman. And I went, oh, we're colored again. Okay, we're a colored woman. So any old way, I wanted to put that out there, because I think the bigger issues around all of this, whether we're talking pipeline or whether we're talking staffing and the short haul, or whether we're talking about the access issues, they really are those social determinants, and they're upstream, and they start actually in grade school. We've got to really start working from grade school to grad school. Craig Hospital is where I am the CEO and president, and I've had this role now for 2 years, which makes no sense. I practiced OBGYN for 25 years, and then the subsequent 10 years was pure play administrator, and I guess doors open and you walk through them and you find yourself running a nationally renowned acute rehabilitation hospital for spinal cord and brain injured patients. Some time ago, Craig Hospital actually had a remote program and went down to Navajo country. I'm not sure how often a year, but delivered services down on the reservation. And I'd love for us, as one of the many things on my list of things to do, to figure out how to rekindle that connection. Both because I think it's important for our staff to see people who are different, and to have some sort of sense of what life after spinal cord and brain injuries look like in communities that aren't able to have even modest home modifications, let alone tricked out, totally beautiful modified homes. So what I do know for sure, being here, and why I think this issue and this topic is incredibly important, has to do with intersectionality. You take any one of these two devastating, catastrophic injuries that we're able to do remarkable, remarkable, remarkable things. I get to see miracles happen every day in this hospital. And you put race or you put ethnicity on top of it, and we know that these are frankly marginalized populations for a host of all sorts of implicit and explicit ways that bias plays out. But you put race and ethnicity on top of these disabilities, and the issues of marginalization are even greater. Economic opportunity, the unemployment rates among those with disabilities, in particular these two, are they completely gulf all the others that we may think about in terms of what those look like, and then stick these others on it and it's worse. So I think in terms of what I'd say, in terms of I think the work ahead with respect to all of what we are talking about today is, and while I am, probably this is the most political thing I will say today, I promise. Saturday couldn't have been a better time to exhale just a tiny bit, because we're not done yet. I think there's a lot of reason to be optimistic, but I think that a lot of that optimism honestly needs to be curbed in the sense of it's relative to what we've endured these 4 years. We have a ton of makeup to do. There are ways from the perspective of even the expression of race and history and ethnicity, let alone the awakening that we're all having as we learn our history. Mary, you beautifully talked about that we don't have a good handle or even sense of the Native American history, except the very, very superficial stories that are told in history. The same goes for Black African American history in this country too. The reading, the things that I personally had darn near 63 of doing now, it's enough to drag you to your knees in terms of what it is required. And so what we have to do in the advocacy space, and I did want to spend about 2 seconds talking there, is that we really do need to become way more policy, sadly, politically activated. And there's something about this moment we're living in where we have the opportunity, and it has to be more than a prayer, but we have to be intentional about making sure that we seize this moment and take on these issues and do it in a coordinated, cohesive, coherent way where we don't actually end up, which sadly has also been sort of the story of all of us folks who are different in this country, where we're fighting over crumbs while the real big dollars and the real big prizes continue to go to others. And I'd end by saying, especially since you're in Minnesota, Mary, that we also need to recognize that we're also facing an economic disparity story that's going on too, that is going to have to be bridged with our poor white American residents and citizens as well, or it is just going to continue to be this ugly, divisive thing. My aunt, who's 93, 94, used to say it's the haves and the have-nots, and we are at that battleground right now. So that's what I sort of throw into the room.
I agree. And Jandel, I just want to say one thing that Václav Havel said, you need a parallel universe to politics. And I think we do need that. You know, we need strong political systems that work well. And we also need parallel universes of people who represent uncommon collaborators that can get major levers moving.
Yes.
Well put.
Thanks.
Thank you, Dr. Allen Davis. Really tremendous points. You know, there's such a rich group of comments that were shared here, and I tried to bucket some of them into a few groups. And I thought maybe we could just sort of kick around some of these issues and frankly, you also drive the conversation. So the things that when I was bucketing the comment from the entire panel thus far have been in sort of the cultural competence of training and education and increasing the pipeline for healthcare providers. So I'd love to talk, particularly Mary and Shri, about that. And frankly, Jessica, if you can weigh in a little bit on how digital tools might, in some level, even expand our ability to educate. And then the other area really is around the structural determinants themselves. And we sort of talked about not just sort of identifying what are the underpinning issues, but what are, to your final point, Dr. Allen Davis, what are the policy and advocacy strategies that we can take to start to address some of these underlying, let's call them social determinants of health. So those are the kind of buckets that I identified. Maybe we'll start off with this cultural competency and increasing the pipeline of healthcare providers as a place to start, and then we can go from there. And I'll leave that as a jump ball, maybe Shri and Mary to sort of pick it up and run with that.
So I want to jump in on this one. I have a problem with the term cultural competence, and because I think it's so much more. You know, you can learn about my culture, but that's not going to help you recognize how critical housing or jobs or autonomy are to me. So I don't want to stop there. And I know that you know that you're just using that term for this discussion. But in my school, we now have 9 hours of required curriculum on Native health. And for me, it's critical that I teach those lectures of history that I just talked about. But then we jump immediately in that last 2 lectures at least into those structural determinants of health at proximal, intermediate, and distal. And we talk, I don't want to talk anymore about giving my patients tickets to get, or bus tickets to get to my clinic, or giving them food coupons. I want to talk about those intermediate and distal factors. I want my students to think about, there's an article that just came out in a journal that I have on my table about the importance of exercise and how it can change it can change the mortality and morbidity of 1/3 of diabetic patients if you can get them to exercise. How do I get them to exercise though when they are struggling with the scarcity in their lives and with social determinants of health? That's what I want to bring to my patients or to my students. Let's talk about this. How do we get them to exercise, but recognize that they might not have a home, that they don't have access to food, that they don't have, every day they walk outside, they are judged to be maybe a criminal or someone who wants drugs or money for not working, whatever, you know. How do we get there using that context? That's where I'm working with the students on. And I think we need to do this nationally. And I so appreciate Dr. Allen Davis, your statements about class. We can work all we want on this race, but unless, like Dr. Martin Luther King and Malcolm have pointed out, unless we address the burning house, we're not going to get anywhere. So I don't want to just talk about culture or about race. I want to talk about these other issues and how they frame what's happening in our communities or how they impact each step of the way. Lastly, I will say the other piece that I teach them is everything's political. I don't care what you say. Natives, if you're born Native in this country, or if you're born African-American in this country, your life is political. So let's get busy.
Yeah. You know, one thing that if I could just real quickly throw in is these conversations, and I think this is really important for the audience to know, let alone for us to be mindful of, is they all have an undertone of not thinking through assets. We think about these as asset poor communities instead of asset rich, and we really do need to make sure we're positioned in these conversations through the lens of asset richness. Because I will tell you, folk make it on way less than any of us around here know, any of us on this thing right now have, and the resourcefulness, the social capital, especially I'd say on the reservations. I would love to see the level of social cohesion. There are issues, we know that. There are issues in all communities, the stressors, mental health, et cetera, et cetera. But there's if there's something that is wonderful from an asset base that we can work from in the Native American communities that my community doesn't have because of the historical way that we find ourselves here, is a lot more social capital than we do. So these are asset rich places, and we shouldn't be thinking them as places full of deficits to fix. And that's not just me preaching, that's really critical as we think about all the issues that we have to come in. And what that really absolutely drive and require is that the people with the problem, the people with the opportunity, the people who've been making it in these communities, despite us, or seriously, despite the power structures, are the ones who must be at the table. And we have to have, put our arrogance aside and listen. And the hour in some ways is us, not just white folk. It's the power structure. So
I completely agree, but we also have to include at the table the people who are not making it, and to tell us why and what.
yes. I mean, it's the communities. You know, it's not just us coming in to do things to them and thinking because we've made you, because you're culturally proficient or culturally competent, you know how to do things. So.
I mean, I completely agree with both of you. Both from the resilience standpoint, I think like a lot of our Native colleagues will say, you know, we were never meant to survive, and in some ways, like we have continued to survive, and we're continuing to be resilient. And so, how do we really anchor to that piece of, you know, the resilience despite what has been thrown at a lot of our Native communities by this country? And then I think secondly is the structural competency piece, because that's something that HEAL, the program that we are on, really anchors on, because I think medical education almost takes out a power analysis from why certain people are suffering or certain people are dying, certain communities. And it kind of, oftentimes it's a interpersonal relationship where the blame gets put on the patient, right? We have an entire language on like non-adherence or loss to follow-up, or you know, just poor historian. Like the entire language of medicine is to distance yourself from your patient, and also put the not actually have a power analysis of why certain outcomes are happening or why are your patients suffering, and taking some of the resilient pieces, both in Native communities, Black communities. I think global health, you know, the community health worker model, and in Alaska that are done so incredibly well. How do we learn from these pieces? Because like, you know, I think that for most doctors, you know, the home visit of actually like knocking on a patient's door and checking on them after you've discharged them is incredibly, you know, insightful, and shifts your, you know, just walking that distance to taking like half a day to walk to where your patient comes from in internationally, or taking the bus in Los Angeles, I think is informative. Walking, you know, knocking on a door, and a lot of doctors and nurses don't have that context. And so how do we, you know, really anchor to the root causes of disease? And a lot of those are structural causes that are not taught in medical school. And so part of HEAL is like coming back to why people went into medicine in the first place, is to serve these underserved communities. But oftentimes, like, our training has not given us any of the tools to really address a lot of the underlying reasons people are suffering.
Yeah, sure. You know, to build on that, it's always curious how, in many ways, the healthcare systems are cordoned off from the very community that they're purporting to serve. I mean, they're, you know, physically sometimes cordoned off, and the expectation is that the ill will come to the physician in some sort of cordoned off area. And to really sort of turn that on its head and say, how do we reach out into the community, build the partnerships, the competent partnerships, to actually become a community actor and not sort of wait for disease to come to us, is, I think, really a real future direction. And, you know, at a practical level, I'll give this from our perspective in J&J, we've traditionally looked at our customers as being a healthcare system. So we talk to a CEO and a procurement officer, and then our job is done when products and services are dropped off at the front door. But what does it mean for a healthcare company to now actually partner with community organizations to create mobile healthcare units, for example, that move out into the community is, to me, sort of a, kind of a next generation of thinking about how do we become more of an active participant in the community itself.
On a good note, I am also on admissions at my medical school. And in the past, I had, in the last couple of cycles, I'm seeing more students who are saying, I want to be a community doctor. I want to be out in the community. And I recently heard one say to me, I don't want the patient to have to come to me. I should be going out to them in their place. It's like, yeah, you go. This young generation, I tell you, it's exciting.
Kaiser Permanente, that big company that I worked for 24 years, built its first medical office, and all of the medical offices they have all over this country, in California, in Watts. It was the first one. And it was just opened like 2 years ago. All those offices, it's been around since 1945, made the pivot or woke up. Who knows? I mean, I'm being somewhat facetious because I still bleed Kaiser blue, having been there 24 and a half years. But one of the things we realized is exactly the point you all are making, is that we talk this health equity, we talk this access, and we make it really difficult for people to actually access care. So they relied on the community, employed people within the community to staff that office to the fullest extent they could.
In my curriculum, I'm trying to do something that's, I always think about Bryant Stevenson's push to encourage people to get proximate. So how do we do that, but keep our patients safe at the same time? How do we, particularly vulnerable patients, so in a real way, so they're not just sitting across and interviewing somebody, but actually working with them together on to solve a problem, or advocating for them, going to doctor's visits with them. So that's the next.
I think that the piece of the puzzle I'll bring in here is just imagine you can take, Mary, your curriculum, your voice, you recorded in 3-minute micro lessons, all the teachings that you wanted to teach, all of the community health workers, making that audio two-way texting available to folks who even can't see you face to face, or bring those community health workers into the curriculum building process and make it mobile first. That's essentially what we've been working to do. And even those who have been, I would say, the advocates for themselves, but not heard. So we have a gender-based violence programming in response to COVID-19. And these young girls themselves are the voices of the recorded lessons and what they would do for prevention and support of each other. And they become the stackable audio lessons that actually lead to the 8 hours of training that somebody can get even over a feature phone. So I'm just trying to illustrate ways we can take some of the best practices and provide a mobile arm where in-person is impossible, where digital online access is impossible, and where people can speak for themselves and provide a tool that's customizable to do so. I want to continue to encourage examples like that and share examples like that, because it's really incredible to see when people take a tool and make it their own, that it can really flip the script.
Absolutely, and I think it's, of course, the case that COVID necessarily is broadening the way that we apply and practice medicine. And so telemedicine technologies that have in the past been used somewhat sparingly are becoming a routine. There are a couple of particularly programs in head and neck, for example, evaluation, where the images are acquired and then they're shared with head and neck surgeons who review at a later time. So we have if you're going to make something of the horrific, disaster of COVID-19 and its management, is to think about more broadly how we can reach as many patients as possible using these digital tools.
I think if you're going to talk, that it's critical that we push for broadband access in all areas then.
It's gonna, this use of telehealth is gonna lay bare yet again, the digital divide.
Right.
When I can't imagine what it must be like on Navajo now to try to do, what we're trying to get done there with using we're having to do now with distance medicine, but I'd wonder though, given that Alaska had this amazing system of being able to do remote care to areas where you can't even only way in is by air at certain times of the year, are there lessons we can learn there? But absent broadband, we're going to still leave a significant number of folks unable to participate. And I don't mean to sound whiny. I think this is one of the policy issues that we've got to deal with in this country.
In Alaska, we were able to pool our money though. And I think that helps significantly to get those communications going.
Yeah,
they are powerful. I took care of patients who were very far away when I was in Juneau. That's my home. So
yeah.
As in Navajo Nation is detailed like a lot of the CARES money to try to improve internet access, that infrastructure. So I think it is a huge priority. And going back to, I think, Mary, what you said, one of the biggest barriers for people applying to HEAL is actually post-residency, right? For a lot of the folks that aren't Native, and the amount of debt burden is massive. And so people that even want to do this work that has a strong social mission and a strong structural lens have trouble entering. And then, not to speak of like the amount of Native, like it's very difficult to recruit Native, because like what you said, the pipeline of people that are coming out of medical school that have finally ended medical school and residency and to apply to this work and take a pay cut and have debt and all of those things, that pool is smaller and smaller. And so how do we grow from the from the elementary school to medical school to residency, that group of people? Because like I think this weekend I have a 5-year-old and her watching Kamala Harris on TV. It's you can't be what you can't see, and if you can't have more Native folks in medicine, in nursing, how are you going to inspire more and more people to join in that pipeline, right? So
I really think our pipeline starts in utero though. When we're taking care of those babies when they're in mom and taking care of mom, then they have a much better start. So
Amen.
But yeah, Shri, it makes me wonder about what you guys can do to change it so that the financial piece, so that you can get more Native input. Of all programs that need to have Native people involved,
we have a primary care shortage that is only going to get bigger. And I'm telling you, I'm going to beat this drum until I die to say we've got to bring the National Health Service Corps back. We really do. I mean, it would free people up to make decisions, and even if you choose to go into specialty, you're going to do it after you do your 4 years, right? In an underserved area, and a number of people never leave when they go. They go and do their time, and I've got friends who are still there, and that was 92 we left. And
we need to incentivize it even more, because a lot of people do leave, and that's fairly traumatic in our communities.
Yeah.
Yeah, it's interesting, Mary. I think your point that you made earlier about there's a certain drive for social impact, at least that I see in medical students and residents as well. And I do think that if we provide the opportunities, I think there's a mindset that exists among junior medical professionals and among medical students that I think could fulfill some of these roles. I think as long as we sort of, like HEAL does, sort of allow that template to actually live into that desire to have social impact, I think we'll see those numbers increase.
This conversation that we're having, I was just on a different one yesterday or the day before, I don't remember, with the AMA. And it's not a new conversation for us, right? But it certainly is in this country. And it feels so different in medical school right now. I've been wanting for 20 years since I first sat down in medical school to have these conversations, and been so frustrated that we weren't. And now today, just boom, with COVID and the killing of George Floyd, it's unbelievable. But hopefully, I think you said it, Pierre, we can sustain it with this new administration. But I think it's going to take pressure from us.
Yeah,
it's so easy for people to say, "Oh, we're good, he's gone," and that is not the case.
Yeah, there's a lot of work to do. There's a lot of work to do cross sector. But one of the hopes that we have, Mary, is that young students who are, freshmen in high school, that they can watch a panel like this and they can see themselves in you, that you were first gen and you went to medical school, and then that becomes a dream that they see themselves fulfilling. And part of it right now is in our K-12 and also in higher ed, there are not a lot of these leaders that look like each of you. And that is a big reason why we really believe you've got to get these role models out there visibly in front of all different kinds of students. And then also to show how all kinds of people from all different backgrounds work together to get major things done. Because then even a, Caucasian, rural, middle of Minnesota, wherever, person can understand, wow, I have some insight from Dr. Alan Davis. I have some insight from Sri. I have some insight from listening to Dr. Owen. And all of a sudden, like, their world is made more broad of people that they might be working shoulder to shoulder with someday. And I think we need all of these different factors at the same time happening.
That's a perfect note. And Carol, first of all, I'd like to thank all of our panelists for really a fantastic organic discussion, and I couldn't have hoped for more. And for all of those that are joining us today, I really appreciate you having taken the time to listen in to what I think are critical issues related to health equity across education, across policy, and across sort of the future of our practices of medicine. Carol, maybe I can turn it over to you for to closure to the discussion.
You bet. And I want to just say that this is First Generation to College Week. And so Pierre and Mary and Jandel, we have so many awesome people. Sri, our First Generation to College role models. So we have a lot of students who read our newsletters every day, and they see themselves in all of you. And we're really honored. We're going to follow up and make sure we can feature Mary's story and her path of what it was like. To be the first, and probably not a lot of people from Juneau ended up, going to medical school as she did. So I'd just like to thank all of you. And also, Mary, I think Monique and Pierre would be thrilled if one of these sessions in the next couple of months that you could lead with a lot of your different leaders from your community, and that we could all really listen and learn from some of your doctors on the ground and some of your people who are teaching the pipeline as well. And I think be awesome, with Jandel someday to do something around the population that you serve that is tremendous, and to learn more about Heal with Sri, and to keep tabs on everything that Jessica's doing. So we really see this health equity team as uncommon collaborators who can really come together at this critical time, because there are a lot of different things that have to be solved, but it won't be solved unless we're forging these critical relationships that are really cross-pollinated in nature. So we did live stream this to Facebook. So if you guys are on Facebook, you can share that out. But Celeste will be following up with everybody who attended, and some of the people who attended the last couple of sessions. We'll have a live video link of this that you can share out with your networks. And any other questions, please put these things, questions or comments, in the chat. And we'll stay on for a little bit so that you can get your questions in there, and we can answer those as part of our follow-up to each of you. So thank you so much for all of you and the incredible work that you're doing, and just the opportunity to work with each of you to close the equity gap at this really critical time in history in the US and in the world. So thank you so much, and we'll see you next month. We're here on the first Monday of every month. So thanks again, and I'll stay on, and we'll gather questions for follow-up.
Everybody be safe. Be safe, please.
Thank you, everyone.
Bye.
Take care now.
Thank you.